Hey everybody, welcome to the second Spinal Pass exam session. So we're going to be starting on page 21 of your book and hitting the highlights again. I will point out the most important things to know, hopefully try to give you some little memory tricks that might help, and we will talk about the exam this weekend. I will definitely be doing an exam review and finishing up whatever material you need to know that we haven't already covered for next week's exams. I also have some Quizlets that I'll be sending out and a lot of practice questions so you can best prepare. So if you don't mind trying to fill out the attendance, that'd be cool. But if not, don't worry about it. You can do that on your PDF whenever. All right, so like I said, starting on page 21, we're going to talk about the blood vessels and the ligaments. And this will come back time and time again. A lot of these topics tend to be the most missed questions, which means you'll see them on all three exams. So it's definitely worth becoming familiar with them and comfortable with this material sooner rather than later. All right, so if you remember from your CNS days, not all that long ago, Dr. Torgerud had you draw out the circle of Willis. He really wanted you to understand that. So a little bit of this is coming back from that circle of Willis. So on page 21 and onwards, when we're talking about arteries, important to know is that segmental arteries it's a general term for any blood vessel supplying a vertebral segment. The vertebral artery, however, is a branch of the subclavian artery. So on the right of the diagram right there, and the anterior spinal artery is a branch of the vertebral artery that you can see at the bottom of that diagram. So the most important part of this section is that chart on page 22. This you should know like the back of your hand because these different vertebrae supplied on the left and their associated segmental arteries will come up time and time and time again. So I would definitely spend some time looking at this chart and trying to make it make sense for you. Specifically, things that might not be totally intuitive. For example, your lumbar artery does not include L5. It does not supply L5. Also knowing that L5 is going to be a very unique area, so I'll come back to that. Knowing that that deep cervical artery supplies C7 and T1 exclusively, and the ascending cervical and vertebral artery definitely do not supply C7, but they do supply C1 and C6. So definitely pick out those oddballs. The rib ones should make a lot of sense. So that posterior intercostal artery, that's going anything with intercostal in its intercostal in its name is going to be serving ribs, and then T12 is unique, so there's no rib below the 12th rib. So under that is going to be the subcostal, so it means below the rib. All right, so down here, these lower segmental arteries are going to be some heavy hitters. So definitely know about that lumbar artery and then the segmental arteries that supply L5 to CO1. So when I said that there was something unique about L5, that's going to be the vertebrae that has the greatest potential segmental artery supply. L5 is always going to be the most unique vertebrae. So if you're ever having to pick one out of a list, it's almost always going to be L5 when we're talking about unique features. So moving into some more of those named arteries, you want to start with your spinal artery. So if you're a visual person, I would make a copy of page 28 and try to follow along. I also have some color-coded diagrams later in the slideshow. But so you've got that spinal artery. So that's going to be traveling through the intervertebral foramen. Know that it's going to mix with the epineurium of that mixed spinal nerve. So the spinal artery is traveling with that mixed spinal nerve, and it gets surrounded by the epineurium of the nerve. That's obviously a pretty important detail because if you have any kind of vascular change or disturbance or pathology, it could be affecting that nerve root that's traveling through the intervertebral foramen. So these are jumping around a little bit between page 22 and 23, but for your anterior spinal artery, you can see that on kind of in the middle on the left side of that image. So know that that is going to be found in that anteromedian sulcus, and it's going to be located in the subarachnoid layer. And I'm going to go into more detail about these layers and some ways that you can remember that a little bit better. But so it's the anterior spinal artery, and it's going to be right up against the spinal cord, so touching the spinal cord. Obviously, it's going to be supplying that nervous tissue. Another important part about that anterior spinal artery is that it is not continuous, but it is a bunch of different branches that unite to form that straight up and down artery. So that's on page 23. And I think it's the second point under that anterior spinal artery. Moving along, so these are back on page 22. You got your osseous branches. So osseous means bony. So these are going to be branches that supply bone. So two of those types of bony tissues are the anterior and posterior spinal canal arteries. So those are going to supply bone. And the spinal canal is made up of bone, so I think those fit quite nicely there. When we were talking about last time, the boundaries of the spinal canal and the intervertebral foramen and knowing what is what, that continues to be important. So knowing that that anterior spinal canal artery is going to be on that, obviously it's named for the anterior part of the spinal canal, which is going to be very close to that posterior longitudinal ligament, which forms the anterior boundary. The posterior spinal canal artery, on the other hand, is in front of the ligamentum flavum, and remember that forms the posterior boundary of the spinal canal. Do know that both of those are in the epidural space, and again, that will be a lot easier to look at when we're in the image section. Moving on to radicular arteries, so anterior and posterior radicular arteries. Radicular means root, so those are going to accompany nerve roots. Do know that the posterior radicular artery is going to be the sole supply for the dorsal root ganglia. So the DRG, dorsal means posterior, so those go together nicely as well. When you're supplying a nerve root, you're close to the nervous tissue, which finds you back in the subarachnoid space, which is right up against that nervous tissue. And then finally, we've got our medullary feeder arteries. Note that those are going to pierce the meninges, and the numbers are actually important in this one. So pay attention to the order of numbers, and you need to know that there are 9 anterior and 12 posterior medullary feeders for a total of 21. They're going to arise in that subarachnoid space before they pierce the meninges, but definitely know those numbers, 9 anterior, 12 posterior. All right, so this is a nice little memory trick if you're into it. When we're talking about spaces, if the name of the artery has spinal canal in it, then it's going to be in the epidural space. Remember, epi means on top of, so if you remember all your dural layers, so on top of the dura, that's going to be closer to bony tissue, so spinal canal is going to be supplying the bony tissue. If, however, the artery has spinal or radicular or medullary in its name, know that that's going to be associated with the subarachnoid space. And subarachnoid, underneath the arachnoid, that's going to be right up against, so between the arachnoid and the pia physically touches the spinal cord and the nerve root inside the spinal canal. So that's a nice little trick if you ever forget which is which. Definitely use those two words to help you rule some things in or out. All right, so that posterior spinal artery, this is kind of found on the bottom of page 23, but using the rule that we just talked about, posterior spinal artery, so you know that it's going to be in the subarachnoid space because it is directly supplying nervous tissue. Know that that one's going to be sitting in the posterolateral sulcus. And again, similar to that anterior spinal artery, it is not continuous. So they are similar in many ways, which is kind of helpful. Moving on to page 24. So we talk about your arterial vasa corona. So again, this is an area that's important to know the numbers because he will ask you them on exams and multiple choice questions, and you have to choose what is correct and what is wrong. So definitely know the ranges. So between C3 and C6, you're going to have 4 and 4. 4 longitudinal vessels and 4 communicating vessels. Then below C6, you've got 3 longitudinal and 3 communicating. And the difference in those is because the right and left anterior spinal arteries unite around that C6 level. So below there, there's just a single anterior spinal artery, but there's still 2 posterior spinal arteries. Moving on to intramedullary arteries. Remember we said if medullary is in the name, that's going to be supplying nervous tissue, and it's going to be in that subarachnoid space. So we've got 2 different classifications of those intramedullary arteries. They are going to actually supply the spinal cord itself. They're going to supply the gray and the white matter. And the important things to know about these are that the central or sulcal perforating arteries supply the anterior 2/3 of the spinal cord and most of the gray matter. The peel perforating arteries, on the other hand, supply the posterior 1/3 of the spinal cord. So that comes up often in multiple choice questions, but it could also be a fill in the blank question where Mr. Mortar asks you to name the artery that supplies most of the gray matter in the spinal cord. So your answer in that question would be your central or sulcal perforating artery. Definitely know that it's supplying the anterior 2/3, peel perforating, P and P go together, so it's in the posterior and supplies only 1/3 of it. So these are just more diagrams different than the ones that Mr. Mortar has in his book to help you visualize some of these vessels so you can really understand them. So on the left, that's describing those intramedullary arteries. So you can see how it is split into a 1/3 section and a 2/3 section. So on the anterior side, you have the anterior spinal artery, which gives rise to the central or sulcal perforating arteries. Remember that supplies the anterior 2/3 of the spinal cord and most of the gray matter. So you can see how much of that gray matter is actually supplied by those central or sulcal perforating arteries. On the back side, you can see that there's that posterior spinal artery. Remember there's 2 of them, so there'd be 1 on each side, which is why only half of it is shown. So clearly we're below C6 in this image. And that's going to give off that peel plexus of arteries, which is going to supply the posterior 1/3 of the spinal cord. So what's nice about the veins is that they follow almost the exact same path as the arteries. So when you know the flow of blood coming into the spinal cord, you'll pretty much know the flow of blood coming out of the spinal cord. So the peel veins are going to be what actually drain the spinal cord. So they arise from the capillary beds, and they're going to be closest to the spinal cord, so they're going to be in that subarachnoid space. Those are going to drain into the anterior and posterior longitudinal veins, and those make up that venous vasa corona. So definitely know that the anterior longitudinal and posterior longitudinal veins are the 2 structures that make up that venous vasa corona. That vasa corona is going to be drained by the medullary veins, so both the anterior and posterior, as the blood is traveling out towards the intervertebral foramen. So remember, radicular means root, so the anterior and posterior radicular veins are going to be draining the nerve root, also heading towards that intervertebral foramen. And then finally, we've got these 2 plexuses to talk about. So the anterior internal vertebral venous plexus, so remember that's going to be named for its location in the vertebral column. So it's going to be on the anterior side, which means it's going to be surrounding very close to that posterior longitudinal ligament. And then if you have looked at your vertebrae, you've noticed the large hole in the back of the body of the vertebrae, which is that foramen for the basivertebral vein. So that's going to drain into that anterior internal vertebral venous plexus. So again, that's going to be in the internal space because it's mostly draining from bone and structures outside the spinal cord itself at this point. On the back side of the cord, we've got the posterior internal vertebral venous plexus, and just know its orientation. So that's going to be anterior to the ligamentum flavum. So constantly try to think of where structures would be in the spinal canal. So there's one really incredibly important point about these veins of the spinal cord and the intervertebral veins. Know that they lack valves. So that is it's in that little box on page 25. So the fact that they lack those typical bicuspid valves is very, very, very unique to the veins of the spinal cord and the vertebral column. So know that that could be associated with spreading cancer. So not an ideal scenario. So the books may be set up a little bit backwards because now we start to talk about the different spaces, even though it's been mentioned previously. So if you did not feel comfortable about those spaces when you're talking about the brain in CNS, this would be a good time to review it. So in this image, we've got the vertebral body on the front and the spinous process on the back. And so this is going to hopefully help you to visualize these different spaces. So that underneath that baby blue is that black line that's supposed to be the dura mater. Remember, it goes from the outside dura, arachnoids in the middle, and then pia is sitting right up against the cord. So remember that epidural space is going to be on top of the dura. Epi means on top. Subdural means underneath the dura. So that's going to be between the dura and the arachnoid. And then the subarachnoid is just underneath the arachnoid. So that is between the arachnoid and the pia. So sometimes people have tried to compare all of these different spaces to Mr. Rogers. So he's got his sweater on the outside, which is that dura, his t-shirt or his long sleeve shirt, which is going to be analogous to the arachnoid, and then right up against his body and undershirt would be that pia mater. So if that helps you, there's a weird way to make an analogy. So just remember that rule that we talked about. If the name says spinal canal, know that it's going to be in that epidural space closest to the bone, furthest from the spinal cord. If it has spinal or radicular or medullary in its name, it's going to be in the subarachnoid space because it's going to be supplying that nervous tissue directly. So if you're a chart person, this will be for you. I've broken down all the different arteries, veins, nerves, ligaments, and the fluid that's found in each of these spaces. So all of these are important things to know. As you can see, the subarachnoid space contains the vast majority of everything because, as you can imagine, that's where most of the metabolism is going on and the greatest need for oxygenated blood and nutrients. The epidural space has a few things. It's going to be a lot of stabilizing ligaments and those vessels that supply bony and osseous tissue or drain that bony or osseous tissue. So if you ever get stuck, when in doubt, choose subarachnoid. And do know that the subdural space is only a potential space, so there should be nothing in there. So unless the question that he's asking is where's serous fluid found, that is the only thing that is in that subdural space, unless there has been a trauma. So those fluids on the bottom are also important to know. Okay, so if it feels like everything is repeating itself, it's because it is, which is great because it's a helpful way to learn if you understand what's coming. So back on page 21, we started talking about the arteries, and then we moved into the veins, and then the contents of the vertebral foramen with those different spaces. So page 25. And then now we have these diagrams on page 27, 28, and 29. So all of this material is repeated 3 times in the course of these few pages. So don't feel overwhelmed because there's so many words. This is a lot of repeat. And that should hopefully be helpful, but sometimes it's not so obvious. So what I've done with my diagrams is I've color-coded them, and I've highlighted the most important features to draw your attention to them. And I'll include these in the PDF that I send you. So the yellow on the very outside between those ligamentous boundaries of the spinal canal is going to represent everything in the epidural space. The pink thin line is that subdural space. Remember, that's just a potential space with a tiny bit of serous fluid in there. And then in orange, which is clearly the biggest space because it has the most stuff in it, is that subarachnoid space, which is going to butt right up against the cord, which is surrounded in pia. So that first diagram on page 27 is going to be for your spaces, all of your neural tissue, and your ligaments. So knowing that your dentate ligaments are going to be those small ligamentous structures stabilizing the cord that are made of pia, know that those are going to be in that subarachnoid space. Those kinds of details are what's important. The Hoffman ligaments, on the other hand, you can see them on the anterior side of this vertebral body. I think it's number 15 on the anterior surface. Those are going to be stabilizing the spinal cord by attaching directly into vertebral bodies, intervertebral discs, and even the PLL. So pretty much anything it can get a hold of, it's trying to make sure that the spinal cord isn't sloshing around in there. So these next 2 diagrams, so those are pages 28 and 29. 28 is all of the arteries and 29 is all the veins. So again, I just use that color coordinating system, and then those rules still hold true. So remember, if it has spinal canal in it, that's going to indicate that you're going to be in the epidural space. And pretty much everything else is in the subarachnoid space. Moving on to the spinal cord features. So page 30 to 32, this is quite important. There will be a boatload of test questions that come from these few pages. Okay, so the important takeaway points from this are knowing where all of these features on the spinal cord are, because there will be a bunch of questions about that. So if you look at page 32, in words, pages 30 and 31 are just describing what is shown on the diagram on page 32. So follow in whatever way makes more sense for you. So knowing that the cervical enlargement is going to be between C3 and T1, that kind of makes sense. There's going to be a lot of nervous tissue there because you have your brachial plexus. And then C6 is going to be the greatest transverse diameter. That's a really important point to know. You don't need to know the actual measurements in this case. The lumbar enlargement doesn't have anything to do with the lumbar vertebrae. So it's found between T9 and T12. So a lot of people will get mixed up on this one. Definitely know that your lumbar enlargement is actually found in those lower thoracics. It's going to be the origin for the L1 to S3 cord levels. But remember that those spinal nerves start to travel down before they go through their respective intervertebral foramina. So the spinal cord should terminate at L1 or rarely at L2, and that's going to mark your conus medullaris. So the spinal nerves S4, 5, and CO1 are all going to arrive there. And then below that is all going to be cauda equina. So in the middle of the cauda equina, you saw this in your CNS wet lab, would be your filum terminale internum. So know that that's going to be between that conus medullaris, where the end of the spinal cord is at L1 or maybe L2, all the way down to the inferior tip of that dural cul-de-sac, where all of the other layers of the dura condense. Filum terminale internum is thin, it's very tiny, and it's exclusively made of pia matter. The dural cul-de-sac, know that that's going to be at S2, so that's going to be kind of ensheathing that whole cauda equina. On the outside of that, the dura and arachnoid condense onto that pia mater and form the filum terminale externum. So that's going to attach the dural cul-de-sac from S2 to a bony structure. The bony structure that's going to secure or tether the spinal cord into place is going to be located at CO1 or CO2. So that stands for the coccygeal segments. So we're looking for that coccygeal medullary vestige, and that's going to be where the filum terminale externum connects to the bony spinal column. So if it helps to draw that out or mark all of it in your diagram on page 32, definitely do that. You need to know all of these landmarks. They're super important for you understanding the physiology of the nervous system and the anatomy. So every now and again, Mr. Mortar will bring certain conditions into this anatomy course, and they are important to know. So on the bottom of page 30, he talks about tethered cord syndrome. So you need to know the two things that are most commonly associated with tethered cord syndrome. So they're having a conus medullaris below L1 and having a filum terminale that is greater in thickness than 2 millimeters. This may also be linked to scoliosis, because on page 31, he says that, in quotes on that bottom paragraph, that a tight filum terminale may be associated with abnormal spinal curvatures. So when you think of scoliosis, know that there are two types of bends that are involved in a scoliosis. So there's going to be an axial rotation and a lateral deviation. So I'm sure in class or I hope you went into some discussion on the different types of treatments for tethered cord syndrome. One of the very difficult tasks is trying to relieve the symptomatology of these individuals. So this is definitely a neurosurgical case. They do often clip the tight filum so that the spinal cord isn't experiencing that same stress that's pulling it down and causing a lot of neurological symptoms. However, because that conus medullaris is typically below L1, there's a lot of risks that are involved in where you can actually perform the surgery. So it's very difficult and definitely a neurosurgical consult. Okay, moving on to the bones. So typically the way the bones work in spinal lecture is that he likes to ask you questions about the special and unique features about the bones. You get tested in them typically very heavily in lab. So that would be where you're labeling all kinds of things. So I'm looking forward to hearing what Mr. Mortar has planned for you, because I imagine the lab portion could actually easily be done online by just showing you images. That he would have to make sure are very clearly marked, but that would be doable. So on past bright space, there's a spinal bone past section, and it has a whole bunch of information and videos about going through all the different features of the bone. So I would definitely highly recommend looking at that. If you have a copy of the MASA guide, I would definitely look at that. And we'll go through all the features that we talk about more in your lecture exam for now, but if you have any more questions, please don't hesitate to reach out. All right, so your C1, I've included all the AKAs because on your second exam, you'll typically have to list all the AKAs in your on one of your fill in the blanks. So C1 is atlas, you all know that. C2 is axis or this epistrophius. So you got to believe he wants you to write that out. So unique features about C1, there is no vertebral body and there's no intervertebral disc. Know that fovea dentis is found on C1. We've got C1 and C2 on the same slide, so you can see the facet for the fovea dentis is going to be on C2. So definitely become familiar with that. The fovea dentis is on the posterior surface of the anterior arch of C1, whereas the facet for fovea dentis is on the anterior surface of the odontoid process or the dens, and those articulate with one another. So every now and again he'll interchange those in a multiple choice or which of the following is not true. So if he ever does that, I just think that fovea dentis is the shorter word, so it's going to be on the more important bone, if you want to think of it that way. So you've got your C1. C1 is king in this respect. I'm not going to go through every little detail on the bones, but if you do have questions, please reach out to me. One of the big points that he hits pretty hard, and you will have in your lab exam as well as in your lecture exams, is knowing that there's two different posterior tubercles on C1. So if he's asking you to name a feature of C1, and he's pointing to the posterior corner of the transverse process, that's going to be your posterior tubercle. And then you've also got a posterior tubercle on the posterior arch. So instead of a spinous process, you've got a posterior tubercle. So you have to write out the whole thing. In your lab exam, you'd say, okay, this is C1, and he's pointing at the posterior tubercle of the posterior arch. Know that the dens or the odontoid process is known as the tooth-like projection. I guess it makes sense. Kind of looks like a big weird tooth. And then C2 has a bifid spinous process. That is actually a feature that's unique to all humans. So that's really important. C2 should always, always, always be bifid. You'll see as we go through the rest of the cervical spine and even into the thoracics, the spinous process has changed significantly and they're not really that reliable a feature to look at. But for C2, it's pretty consistent. Moving on to C3 to C5. So those are going to be those typical cervicals. So if you ever get mixed up with your uncinate, I always try to think of put your arms up in the air like your goalposts, and your uncinnates are going to be like those goalposts. They point up, and then the lips, which are found on the anterior and posterior surfaces, are on the bottom part. So uncinnates go up and lips go down. So there's a lot of features to look at on these typical cervicals, but once you can kind of point them out on a single vertebrae, you can point them out on many. So the sulci for the primary rami, you've got two of those. You've got a dorsal one and a ventral one. So ventral means on the front side. So on the front side, if you're looking at the bottom of the picture, that's going to be the front side, and you've got your transverse process, and that costotransverse bar is going to connect the anterior and posterior tubercles on that transverse process. So that's that thin little line that's just in front of the hole. So that's going to be kind of that cup that holds on to the ventral primary rami, and they're pointed anteriorly, remember, because those are going to make up that brachial plexus. And then the dorsal primary rami is going to be on the backside of the articular pillar. So when he draws it in lab, you see that you've got your transverse process and then your articular facets, which are those big things that are bilateral to the body, and it's going to be on the posterior side of that. They'd just be a little line, and that would mark where the sulcus for the dorsal primary rami. All right, then moving up to the uncinnates, remember those are going to be your goalposts on either side of the vertebral body. They point up, and the lips form the anterior and posterior parts coming off of that inferior epiphyseal rim, and the lips lower. Uncinnates are up, lips lower. So the uncinnates and the lips are going to form those joints of Volushka, and we'll get into that a little bit later. C6 is a special air quote typical cervical because it's going to have the carotid tubercle. So that's the big deal about C6. It's got everything else the same as C3 to C5, but it's also got a carotid tubercle. So that's formed from pressure due to the common carotid artery. It's going to look like a little cup. So if you saw it in lab, if you just cup your hands, it looks like that on the anterior tubercle. All right, then the very bottom of the cervical spine, you've got your C7. So I put the AKA here. It's the vertebra prominens. Later on, probably in the next exam, he will again do the AKAs, but a lot of times he'll use vertebral prominence as a distractor. So vertebral prominence is a feature, is just the most prominent vertebrae. So it could be T1, it could technically be C6. It is just the most prominent vertebrae on palpation. However, the vertebra prominens is a specific name for C7. So just getting that into your brain now. So C7 is going to look very similar to the rest of the cervicals. The top half, it's got those goalposts, the uncinnates going up, and then the bottom half starts to look a little bit more like a thoracic because we're getting into that transition zone. So it can't be an abrupt transition. It has to slowly transition from cervical features to thoracic features. So this is where we start to see the spinous process starts to look a lot more like a thoracic, and that's why you can very easily palpate your C7. So know that it's going to be a long horizontal spinous process, and it's non-bifid at C7. Moving into the thoracics. So I thought I would do them from top to bottom. So T1 is actually on page 42. It's going to complete the end of the transition of from cervicals to thoracics. So it's also going to be have a very vertical shape to it, and it has some little projections on that superior epiphyseal rim, but it has no cervical features. So if there was ever a question that asked you or insinuated that T1 had uncinate processes, it absolutely 100% does not. No cervical features, even though it's a little bit cup-shaped. So here we start getting into the rib articulations as well, and I've got some more diagrams to help you understand that a little bit later. So on T1, your very top, your superior costal facet is going to be where rib 1 sits and rests. And then it's going to travel out and rest on the transverse costal facet, which is that articulation on the transverse process. So rib 1's at the top and on the transverse. And then demi means part or half. So on the bottom of T1, we've got a small demi facet, and that's going to be where rib 2 sits. So rib 2 is going to articulate with T1 at the very tip of it. It's going to articulate with the intervertebral disc between T1 and T2, and then it's also going to articulate with T2. So if that's not clear, I have a diagram later on which will hopefully clear things up. And then once we move into the rest of our typical thoracics, we've got 2 different regions. So he breaks them up into these regions because they have very similar features. So T2 to T4 all have very similar features, and then T5 to T8. So when you're having a lab exam, you group them accordingly. You don't have to pick out a T3 segment and name it as T3. You just look at the features, you say, okay, this looks like it's in the grouping of T2 to T4, and then you name the feature that's on that bone. So the T2 to T4 region has less steep spinous processes. We're not getting a whole lot of imbrication in this area. all of T2 to T4 have both superior and inferior costal demifacets on their vertebral body. And then remember, in the thoracics, we have that pars interarticularis, which is that weight-bearing region between the superior and inferior articular facets. Remember, the superior and inferior articular facets form zygapophyseal joints. So the pars interarticularis is the weight-bearing region, and if you recall, in the cervicals, it was called an articular pillar. So it's an articular pillar in the cervicals, and the pars interarticularis everywhere else. So what's unique about, another unique thing, about T2 to T4 is that those pars are a little bit wedge-shaped. So if you hold your arms up like goalposts again and you move your hands away from each other while keeping your elbows close together, they're kind of shaped like that. So a little bit tethered. So the superior part is going to be, they're wider than the inferior part. And that's going to add some stability to that region. T5 to T8, remember we said those are going to be also typical vertebral, thoracic vertebrae, but they are clustered into their own individual group of unique features. So they have significantly steeper spinous processes. This is going to be the heavily imbricated area. And I can get up to 60 degrees of angulation in that spinous. So again, these also have both superior and inferior costal demifacets, but the most definitive feature on the T5 to T8 vertebrae is the aortic impression. So that's going to sit on the left part of the vertebral body, and that is, remember how hard tissue remodels to soft tissue. So the aorta, as it travels down, is going to pulsate against that vertebrae and push the vertebral body in. So you've got a really clear flat spot on the left part of all the vertebrae from T5 to T8. And then the pars interarticularis in this section, so T5 to T8, are no longer wedge-shaped, they're straight up and down. So if you hold your arms up like goalposts again, they are straight up and down. There's no wedging shape there. T9 to T10 are again unique. They may or may not have inferior costal demifacets. So T9 is the first place that the inferior costal demifacet, it might be there or it might not be. And then on T10, it's definitely gone. But again, I've got a diagram, so if that doesn't make a lot of sense, hopefully it will in a little bit. So under the T10 features, he talks about the para-articular process. So that's going to be a typical fill-in for your lecture exam as well as your lab practical. You're definitely going to have a para-articular process. You should know that it is most commonly found at T10, and it's going to be an ossification of the ligamentum flavum. You can't miss it when you see it in your lab practical. It looks like a little spike coming out of the vertebrae. So know how to spell para-articular process. Know that it's going to be ossification of the ligamentum flavum, and know that it's most commonly found at T10. All right, moving on to the last couple of thoracic. So T11 and T12, we start to transition into more lumbar-like vertebrae. So T11 is going to start to assume a lumbar-like shape, and they start to look more reniform. So they kind of assume that kidney bean shape. So as we've been going down the vertebrae, that superior articular facet has started to shift backwards from the body onto the pedicle. So once we get down to T11 and T12, this is super, super clear. So you see the superior costal facet shift further and further back until when you're at T12, it is almost completely on the pedicle. So I skipped this on the last page, I apologize, but at T10, that's the first place you may or may not lose the transverse costal facet. So once you get down to T11 and 12, not only have you lost the inferior costal facet, but you've also lost that transverse costal facet. And it kind of makes sense because from what you've seen of ribs, you know that they start to get a little bit smaller. So you've got rib 11 and 12 are going to be those small, puny, floating ribs. So they're not going to need the same amount of support the big ribs that are supporting more of the chest cavity need. Another unique feature of T12 is that it does not have a transverse process, and that question will come up a lot in your lecture and lab exams. So there is no TVP. It has a superior, inferior, and lateral tubercle. So definitely know that. Get it in your head now. There's no TVP on T12. And the spinous is starting to look more like a lumbar. So it's kind of short and boxy looking. So here are those diagrams I was talking about. I hope you will find them helpful. I found them quite helpful to draw myself. So at the top on the right, that one's mine. So you've got T1 on the top. Remember, you've got rib 1 has a full articulation on the body of T1. So it's going to be a superior costal facet. And then we've got demifacets all the way down until we get down to rib 11. So everything between rib 1 and rib 11 is going to be sitting on two distinct and different vertebrae. So rib 1 sits distinctly on that superior costal facet on the vertebral body of T1, and rib 2 sits on that inferior costal demifacet. Remember, on that transverse costal facet, so that middle part of that diagram on the right is going to show the black is the articulations of the ribs. So rib 1 articulates that transverse costal facet, and then on the very right hand side, that's just a very unartistic line to describe the angle of the spinous process and kind of length. So T1 has a nearly horizontal, very long spinous process. So T2 to T8 are not that special, so their superior and inferior demifacets are going to be very similar in size, and their transverse costal facets are present. So T9 is where things start to get a little bit interesting. So definitely know that rib 9 is going to articulate on the top of that vertebral body. So it's going to sit on the superior costal demifacet. And rib 10 may or may not articulate at the bottom of T9. So that's the first place we might not see an inferior costal demifacet. However, rib 9, which is firmly sitting on the top part of T9, definitely does articulate with a transverse process at T9. And as we're getting lower in the thoracics, those spinous processes go from being very angled and long to starting to shorten up and get a little more horizontal. Then on T10, remember we said in T9, inferior costal facet may or may not be present, so that means on the next segment it's definitely not there. There's no inferior costal facet on T10. And rib 10 is sitting firmly on that superior costal demifacet on T10. This is, however, the first place we may or may not see a rib articulation with a transverse process. So if in doubt, know that rib 10 is where everything gets a little bit questionable. So when you start to talk about the ribs more, you won't even talk about rib 10 because they can be so variable. So rib 10 definitely sits on the superior part of T10, the vertebral body. However, whether it articulates with T10's transverse or the vertebral body above is questionable. It may or may not do that. So rib 10 is where all the question marks happen. And then moving down to T11, you can see those superior articular or costal facets start to shift backwards further off of that vertebral body. So rib 11 shifting back a little bit, rib 12 shifting back a little bit further. Those spinous processes are getting more horizontal, and then T12 is very lumbar-like. So hopefully that helps clear things out. I would recommend drawing it out for yourself just so you're very, very clear, but Rib 10 is where everything gets a little bit strange and we have a lot of question marks. All right, moving into the lumbars. L1 to L4 is going to be the grouping of the typical lumbars. So you can group L1 and L4 pretty much completely together. You're never going to be asked to distinguish an L3 from a group. There's very unique features that make it quite easy to distinguish an L5 with unique features, but L1 to L4 all look very similar. So that vertebral body is very reniform or kidney bean shaped. And then we have two different features that we have not seen on other vertebrae. So you've got the accessory process on the lumbars, and that's going to be an inferior projection. So it's a tiny little bony feature that's sticking off the bottom of the transverse process. And then you've got the mammillary process, which is, it's called a breast-like projection from the superior articular process. So mammillary process is an area that a lot of people somehow get spelling marks taken off of. So mammillary. Know how to spell mammillary. 2 M's, 2 L's. When you get to L5, it's very, very unique. So not only does it have a different shape of its vertebral body, it's going to be a little bit more wedge-shaped, the anterior height greater than the posterior height. It's also going to have a very short spinous process and the shortest of the transverse processes, and those are going to come directly off of the pars. So on the image to the right of the lumbar vertebrae, you can see on that axial or overhead projection, the pedicles are really nicely distinguished from the rest of the vertebrae. So it goes the vertebral body, that attaches to the pedicles, then you have your transverse processes coming off, and then your lamina connect to form your spinous process. L5 doesn't have a very well distinguished pedicle. It kind of just comes off the whole body. It's not distinguished. So I think that's depicted really well in your book on page 47. So comparing that view superiorly to that view on 46, they do look very different. And if you have your bag of bones, I hope you have a chance to go through them. But anyways, that's it for lumbars. So moving on to the sacrum, there's a lot of stuff on the sacrum and Mr. Mortar loves the sacrum, so it's definitely worth spending some time on this. So on the image to the right, we're looking at it posteriorly. So we've got a few different lines to look at. We've got the median sacral crest in purple. So median means a middle or a midline, so this makes sense. And you're going to want to know that that's going to represent a line connecting the spinous tubercles. Remember that the sacrum is formed by fusion of multiple sacral segments. So these were all independent at one point in time and then fused to form the sacrum. So all of these do have analogous features. The intermediate sacral crest, which is in green, that's going to go from the superior articular process of S1, which goes a little bit further than that green line has shown, down to the sacral cornu. So you should know those landmarks, and it's going to represent the articular process. So the sacral cornu down at the very bottom actually represents that inferior articular process of S5. Then in that red color, we've got our lateral sacral crest, so that's going to represent your transverse tubercles. Notice that it's going to be the first line on the opposite side of those sacral foramina. So your S2 tubercle is going to be found in line there. So your S2 tubercle is a unique feature because it tends to be exceptionally large, and it's called the sacral tuberosity. So that's your S2 tubercle, definitely know that. Then at the very bottom, you have your sacral hiatus. So that's going to be a little V that's formed between the medial and intermediate sacral crests. Other important features to know about the sacrum are going to be, so the sacral promontory, if we were looking at the anterior surface of the sacrum, the sacral promontory would be kind of the anterior part of the, what would have been the vertebral body of S1. So just on the top of that there. And then on the anterior side between those sacral foramina, you'd have transverse ridges. So remember when we were talking about bony features, that was way back on page 5. And then I recommended you all look at page 271 to 273. So you know that those transverse ridges are going to be very prominent linear surfaces. Those are going to be found on the sacrum. So associate transverse ridges with the sacrum. And then on page 49, the coccyx, there's nothing too crazy about the coccyx. Just know that the CO1 segments are going to be what were originally coccygeal vertebrae. So you had your CO1, that would have been the vertebral body of the first coccygeal segment, and so on and so forth. There tend to be 4 most commonly, but on your lab practical, when you get back or whenever this happens, he has multiple different types of coccyx, which have varying types of vertebral bodies or varying numbers of coccygeal segments. So they could be CO1 to CO5, so 5 segments, but it's most commonly going to be 4. And on the top of that vertebral body of CO1, you have your coccygeal cornu and then a tiny little transverse process. But it is one single bone with multiple vertebral bodies. Remember, again, just like the sacrum, it starts out as multiple segments and then it fuses to form one. So here's a quick question for you. So we talked about the transverse ridges being found on the sacrum. So I put this here so that you differentiate them and associate these. So transverse lines are definitely not found on the sacrum because we already established that transverse ridges are found on the sacrum. So those are going to be found on the sternum. And then asking about the shape of the vertebral foramen, it continues that similar shape that was in the lumbars, and that's going to be a triangular vertebral foramen. So finally here, we're going to do a quick chat about the sternum. So we already talked about those transverse lines. So the sternum, always associate your transverse lines with the sternum. And then one of the most important parts of this that gets tested very heavily is that second costal notch. So know that that's going to be found both on the manubrium sterni as well as the corpus sterni. So rib 2 is going to articulate both with the manubrium and the corpus. And so we have multiple parts of the sternum. We've got the manubrium sterni, which is that big shield-shaped thing at the top, the corpus sterni, which is the blade, sword-like blade, or the body, and then you've got your xiphoid process, which is that tiny little tip at the bottom, which ossifies very late. So that's pretty much it. You've got a bunch of different sternebrae that make up the sterni, and the ribs articulate there. So then at the bottom, where are those transverse ridges found? Remember the ridges. Ridges go with the sacrum, and lines go with the sternum. And here is a Kahoot that I made for you guys. It's made with very mortar style questions, so he tends to like to ask a lot of questions that are questions within questions. So it's all of the following are true except, or which of the following does not belong. So I did not intentionally make them annoying, and I apologize, but hopefully you find them helpful, and it's good to practice that type of question. So yeah, let me know if you have any requests or any other way that I can help you.